Okay, so without any further questions, why don't we invite Daniel Blau to become the speaker, right? He's going to do a case presentation before our main presenter. Hey, Dan.
Hey, how's it going?
Great.
So, okay, let's see.
Before you get started, do you guys just want to smile for a photo when you get your PowerPoint up?
Yeah, don't forget.
What was that? I missed that.
Just when you, there you go. I just want to grab a photo of you guys before you start. So everyone smile. Well, keep the PowerPoint up if you can.
Where? Oh, sorry.
There you go. Okay, 3, 2, 1.
Okay, so here is my case that I'm presenting that I have been working on with Dr. Hong. So I want to just give a shout out and a thank you to her before getting started. So this case, anterior set is correcting diastema with crowns and veneers. Let's see. Okay, so 41-year-old female comes in with her chief concern that she wants to close the gap in between her two front teeth. Past medical history has high cholesterol. She's taking fenofibrate for. No known drug allergies. Had a breast biopsy a few months ago. And no smoking or alcohol use. So here's our patient at rest and profile view. And here she is smiling. So first, the thing that pops out to me when I look at this is her large number 8 crown that seems to be dominating her smile, along with the space, the diastema that is present between 8 and 9 that she would like to correct. Zooming in, we can see diastema about 1.5 millimeters in width. She has odd contours on number 9 from composite that's been placed there in the past, and shade of her existing number 8 crown is also lighter than all of her other teeth here. Looking from these pictures, we can see that her laterals are pretty narrow, and her canines also more so number 6 and 11, but this will ultimately help us in our overall treatment planning. You can also see a little bit that they're slightly palatally inclined, which will also help us in the end run. Here are occlusal views. On the lower, a little bit of crowding, maybe some mild wear, but you know, overall, caries wise, and she doesn't have much going on in terms of caries. Let me go back for a second. Here, actually, never mind. I'll continue. So here are her bite wings and anterior PAs. You can see that she does have generalized horizontal bone loss, and specifically when we're looking at the uppers here, the upper anteriors, she does have bone loss around 7, 8, and 9. Talking to her about her oral hygiene habits, she does say that she brushes, 3 times a day, flosses daily. But last time she was in, we had a little bit of a deeper discussion on how she can improve these habits, these oral hygiene habits, especially before having these restorations placed, and how to keep these clean. We also see from the radiograph here that number 8 has been treated endodontically in the past. This was done many years ago. I don't think she remembers how long ago it was. You can see the large mesiodistal lingual composite, number 9. Periocharting, she has moderate generalized pocketing. I don't know how well you can see all the numbers, but specifically talking about the upper anterior, she does have some 4s, some 5s. Again, something that she can hopefully improve upon, and we can show her a little bit how to do so. So existing findings, again, generalized moderate chronic periodontitis, number 8 PFM crown with previous RCT and large dimensions of the crown. Number 9 extensive mesiodistal lingual composite, narrow laterals canines, which are palatally inclined, her diastema between 8 and 9, stump shade, amenable for all ceramic crowns. Just go back to the photo from before. The shade of her teeth is pretty good, and she's mostly happy with them. She did request that we make these crowns a little bit lighter than her existing teeth. I think ultimately we chose A1 as our final shade, but if we were to use some material for our crowns that would have more translucency, then her stump shade of her teeth should be suitable for that. That it will still look aesthetically pleasing. So how do we treat this? So before getting into our actual treatment plan, we'll just take a second to talk about this golden proportion. So, throughout history, scholars have studied sort of certain golden ratios, whether it's in music or art, nature, whatever it may be, that there are mathematical basings for things to be aesthetically pleasing to us visually. So people have studied this golden proportion for dentistry. So I was looking at a bunch of studies that people have done, and they seem to not conclusively say that there actually is a golden proportion of what we consider to be aesthetically pleasing. Taking digital scans of hundreds of people, measuring their teeth, comparing them, what they might find to be aesthetically acceptable didn't necessarily fit our golden proportion, our golden ratio, but conceptually, this is what would help us in determining how we want our final restorations to look. So this golden proportion, we see on the right, something similar to 65%, looking straight on from a facial view. The mesiodistal width of the lateral should be approximately 65% the width of the central, and then the canine approximately 85% of the lateral. And these proportions, these ratios, should give us something that we as the clinician and the patient will ultimately be happy with as a result. So getting into our actual treatment plan, originally this patient was treatment planned just for crowns on 8 and 9. But however, if we were to only plan crowns for 8 and 9, we would certainly be violating this golden proportion that we would ultimately like to achieve. So luckily for us, based on the way her laterals and her canines are shaped, their narrow dimensions, their inclination, we can borrow space from those teeth in order to fabricate something that will fit our golden proportions and something that will ultimately be happy with and will look nice. So we treatment planned her for Emax crowns on 8 and 9, 8 to replace the existing crown, 9 because she has that large filling that's there, and then veneers, Emax veneers on 6, 7, 10, and 11, and we're going to use the same materials to achieve an optimal result. We can get the best aesthetics using the same material, hopefully. So our steps for going through this case versus taking our models and doing composite mock-up of those 6 anterior teeth, prepping and temping the centrals, and then adding composite on the mesials of the lateral to adjust for that space that was lost on the distals of our centrals when we brought them in and shortened them mesiodistally. Then prep the laterals and the canines for the veneers, impression for our veneers. We deliver our veneers, then impression for our crowns, and then deliver our 8 and 9 crowns. You might ask, why are we doing these 2 in steps? Why not all together at the same time? This is to adjust for the possible discrepancy in translucency of the veneers compared to our crowns. If we deliver our veneers first, then based on how those look, we can kind of we can try to replicate that sort of translucency on our crowns. So here's our mock-up that we did, borrowing space from our laterals and our canines. Because of their palatal inclination, we're able to bulk them up and build them out a little bit, make them more prominent, made sure that our gingival contours look nice, and we have a good sort of emergence profile coming from the gingiva. Midline marked based on our bite, and let's keep going. And then hand articulating it to our lower model, making sure that even after the mock-up, we can still articulate it, so that hopefully there are fewer adjustments we have to make once we deliver our temps. We also took an impression of our mock-up with a light body wash in order to, when we make our temps, we can best capture those embrasures. Again, fewer adjustments that we have to make on our temps, and will just look more natural. Additionally, we also took this, we made this plastic tray as our sort of reduction matrix. Okay. So 8 and 9 were then prepped for crowns. We sectioned number 8 PFM crown, Luxatemp splinted provisionals, temporarily cemented, and cleaned the excess cement and removed the flash, because especially with her periodontal issues, we don't want to cause any more problems. Added composite to the mesials of 7 and 10. As we were prepping, she had some thin dentin on number 9. You could see the redness of the pulp chamber beneath the dentin. She started having some sensitivity towards the end of the appointment. So we were going to monitor symptoms for a couple weeks and see how she does. And we chose our final shade A1. So here are our temps of just 8 and 9. They're a little bit long in the incised gingivally, but we were able to take that down a little bit. Okay. So yeah, my biggest regret with this case was that I forgot to take a picture of the veneer preps. So I can't go back now, but these are actually pretty close. I just found this stock photo. This is pretty close to what the preps looked like. So we broke the distal contacts on the veneer preps to allow room for mesial material. We temporized with Luxa crown. Another regret going back, I would have used the same temporary material. For the centrals, we used Luxa temp. For the laterals and the canines, used Luxa crown, only because Luxa crown would have given a little more strength for a really thin veneer temps, but the shades were not matching, so I'll show a picture. But they were temporary, and patient was totally fine with that. So, and number 9 ultimately had been sensitive to temperatures for past couple of weeks. She was having some sensitivity, so we treatment planned root canal on number 9. And here is our completed root canal. Okay. And here's a picture of the patient after our temporaries are delivered, 6 through 11. So you can see the shade of the centrals a little bit different from our laterals and our canines, but again, she was okay with this. She's okay with it. I'm okay with it right now. 2 weeks later, we delivered our veneers, cemented with translucent resin cement, and she is very happy from this picture. So here, okay. So next steps. So this case isn't done, but hoping to finish within the next month or so. We'll do fiber post cores on 8 and 9. Right, that's something that I have to get my hands on. We have to order because right now we actually only have the titanium posts in the clinic, and that'll likely show through on our translucent Emax restorations. We'll also then refine our crown preps on 8 and 9, take our impression, and then hopefully deliver our crowns. And these are just a couple of the studies from researching those golden proportions. Okay, and that's our case. And if anyone wants to see the final results, you can, of course, reach out to me. And yeah, if anyone has questions, feel free to ask. Okay.
Anybody have their hands up?
Okay, we just got a few. Give me 1 second to pull them up. Okay, somebody has their hand up. Where'd you go? Okay, Dr. Moskowitz, we're gonna call on you. Okay, you should be able to speak now. Dr. Moskowitz, do you have a question? Okay, I'll give him another minute. Dr. Glazer said, nice presentation.
Thank you, Dr. Glazer.
And I don't see anything else besides, oh wait, hold on, Dr. Garash just got his hand up. Let me move over to him. Hi, Dr. Garashi. Do you have a question? You're on mute currently. If you can, oh, hold on, it's coming through the chat. It says, great presentation. What resin bonding cement system did you use?
We used Reliax resin cement.
Okay, let me just lower hands. Hold on, we've got another question. Could you rank how you did composite mock-up? Could you rank how you did?
Rank it? Do I like it, you're saying?
Yeah, can we clarify that question? Can you rank how did you do composite mock-up? Let's give it a minute to see if it comes through. I'm sorry, I'm not sure.
Hey, Dr. Blau, I have a question.
Yeah, what's up?
Number 9, are you gonna put a post?
Yeah.
Or, okay, gotcha.
Mm-hmm. Yeah, they're
And
trying to go back, but
so it was just irritated from the prep. So why you didn't lose a lot of tooth structure there? So why would you put a
well,
post?
the composite. She had that really large composite there
Right.
prior. So after prepping and removing a lot of that, they're really the dentin was really thin.
Gotcha,
I think it was
gotcha.
unusual, so hopefully it'll
Okay.
just give it a little more strength.
Right. Veneers looks great.
Thank you. And thank you to Mr. Choi also in the lab.
Yeah, great case, Dan. I have a question for you.
Mm-hmm.
So if tooth number 9 didn't have such a large composite, would you still do a crown on it with 8 needing a crown? Or would you consider doing a veneer on number 9 and a crown on 8? And what would be the dilemma? That's just treatment planning questions for you.
No, it's a good question. I guess getting back to one of the points that I made earlier regarding the discrepancy and the translucency between the veneers and the crowns. I guess it's possible that you have I guess what's the word I'm looking for? I don't know. They're adjacent 8 and 9. You pair 8 and 9 with the same type of restoration, you might get a better aesthetic result as opposed to doing all veneers and then one tooth out of all of them has a crown. So from that standpoint, maybe you would consider doing 2 crowns on the centrals. However, then you're getting into, if it's healthy tooth structure that hasn't been tampered with in the past, you're taking away more tooth structure, which you don't necessarily need to take away. So I guess it's preference by the clinician. I don't know if you have a specific preference or if there's a right answer.
That's a tough call. And no right and wrong, because you're right. One would be more conservative, do the veneers. You're going to have patients ask you that sometimes. But it's really a clinical challenge when you're doing a crown next to a veneer on those adjacent teeth. Sometimes we do it for, something breaks and we have to do it. So I don't have the answer myself. I know it's simpler to just do 2 crowns. Symmetrical is the best, definitely. In your restoration, in your sizes, no doubt. It's the easiest for sure. So that's a tough call.
Dr. Glazer said it's always difficult to match crown and veneer, especially upper anteriors. I think Dan handled correctly with 2 crowns.
Oh yeah, definitely. I agree. I agree.
A clarification for that question never came in, so I am going to suggest that we move on from that. And if a question ever comes in, I can send it to Dr. Blau and get the clarification.
Awesome. Sounds good.
Thank you, Dr. Blau.
Great
Thank
job,
you.
Dr. Blau.
Thank you, Dr. Minichetti. How do I stop
Thanks
sharing?
to Dr. Hung for helping you
Yes,
out with that.
thank you so much, Dr. Hong.
I just took it away from you. I gave it to Dr. Lipkin now, so you're good.
Thank you.
Hi, Dr. Lipkin. I can see you and I can see your screen, but
Yeah.
I cannot hear you. Oh, there you are.
Can you hear me? Perfect.
Now, perfect.
Hey, Dr. Lipkin, how you doing?
How are you, John?
Great. We're excited to
All
have you
right.
this evening. Thanks for coming on.
Thank you for having me. So let me, there we go.
I'm going to do a little intro and I'll turn it over to you, okay?
Sure.
Perfect. Are you set to go?
Let me just check something real quick.
Sure.
Okay. No, it's okay. Yeah, I'm ready.
Awesome. So Dr. Lipkin immigrated to this country in 1990, and he worked full time while getting a bachelor's degree from NYU and graduated from NYU's. Got it into NYU's College of Dentistry and did a postgraduate at their orthodontic program. He's got professional awards in excellence in general practice of dentistry and human values. He's got a certificate of recognition from NYU and from the Orthodontics Honors Program. He's also, and the program's Director's Award and an Achievement Award, quite a few awards. He earned the Honors Award from the American Association of Orthodontists Foundation and an award for the exceptional interest in the development of oral facial complex from the American Association of Orthodontists also. He's a member of the American Association of Orthodontists, the ADA, the New Jersey Dental Association. He's board certified in orthodontics, and he's a member of the Roth Williams International Society of Orthodontics. So we are happy to have Dr. Lipkin lecture and join our general practice faculty in helping our residency program. Thank you for coming on this evening and spending some time with us in this program.
Thank you so much. So let me get started. You could see my screen, right? I'm assuming.
Yes, I could see it.
Looks good.
All right. Perfect. So this is me. I'm in Westwood, New Jersey, not too far from here. Have been here since September 11, 2001 was my first day. So I'm here today to share some of the newest technologies in orthodontics that makes orthodontic treatment and makes interdisciplinary treatment a lot easier and more predictable. So what do we want from our treatments in general? We want precision, especially from orthodontic treatment. We want precision in diagnosis, precision in treatment, absolute control of tooth movement, and we want it fast. You tell the patients they're going to be wearing some appliances for a while. They want to be done tomorrow. I'd like to introduce you to a concept of 3D digital orthodontics, how the treatment has become a lot less invasive, precise and faster, better quality with less time. I'll show you some complicated cases that become way more predictable with some of the technologies that some of you, I'm sure, have heard of and some may not. And then also how today some of the technologies turned orthodontics into a healthcare more than just tooth alignment. So let me start with the conventional orthodontics. In conventional orthodontics, precision in diagnosis is just done by two-dimensional X-rays, like a Panorex and Ceph, and it's really distorted X-ray. And I'll show you why. Precision in treatment is, since a lot of orthodontists just evaluate the tooth positions just when the patient gets in the chair. So I'm sure a lot of people who are listening to this had experience being treated by an orthodontist. And, you come to an orthodontist, patient gets in the chair, the orthodontist looks and then says, okay, today we're going to do this wire or that wire. And sometimes it takes a long time. Absolute control of tooth movement is certainly possible, but not very predictable. And in general, the national average is about 27 months of treatment. So, even insurance companies say, if the patient goes for an orthodontic treatment, it's 2-year process. Now, with the digital 3D orthodontics, precision in diagnosis is very high. Not everyone knows what cone beam is, and I'm going to introduce you to a technology called SureSmile, which you probably heard of. Precision in treatment, tooth position could be visualized to the 10th of a millimeter and guided there, including root surfaces, contact points, etc. Also using cone beam and SureSmile. We could move the teeth very, very precisely using that SureSmile and also TADS, again, something everybody's heard of. I remember a story where when I bought my practice, the gentleman who I bought the practice from, Dr. Angelo Nivaji, he was on the phone with the general dentist, and she asked him to move certain teeth certain way, and then he said yes, 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 and after he hung up the phone, he was kind of frustratingly said, well, does she think this teeth set in wax? So today is really in a way that that's changed, because we could really move teeth wherever we want. And speed of treatment, the average is about a year time, and there are some techniques that make it even quicker. All right, so let's start with diagnostic precision. Again, most orthodontists on the planet, I shall say, take cephalometric and panoramic X-rays, and what you see is what you get, but is it really accurate? So when you look at the panoramic X-ray, if you take, for example, a lower jaw and then put a piece of wax over it with 3 little BBs, that's how you would want to see it on the X-ray. But reality is, on the panoramic X-ray, comes out like this. It has a lot of distortion. These BBs do not come identical. So the conventional technology is very, very clear, very nice, but it's not very accurate. So we have something that's called cone beam, and I particularly in my office, I have an iCat. I've had an iCat since 2005. I think I was the second dentist in New Jersey that got the cone beam in 2005. But it's really, no looking back, it's been an amazing, and then I don't think I could be practicing without it today. And it really enhances the view. I'm not going to spend too much time on it. It's really a remarkable technology that lets us see things very, very detailed in 3D, and also make a nice Halloween movies out of it, like that one. And then from this volume, you could get a reconstructed X-rays. You could get Panorex, Ceph. You could merge it with a facial camera and have a diagnostic capabilities that are really, really amazing. Cone beams today are really, really low in radiation. For example, the iCat Flex, the current generation, is a 5-second scan, only gives you 8 microsieverts of radiation, with the daily background being 8 microsieverts. So basically, if you take a 5-second diagnostic scan on a cone beam on the iCat Flex, it's like walking around for a day. In comparison, panoramic 10-15 microsieverts, digital pen 5 to 15. Film pen is 26, so film pen is a lot more radiation than the iCat Flex cone beam. Full mouth series 150, medical CT 1200 to 3300. So cone beam radiation is really abysmal. A little funny picture of 4 out of 5 dentists recommend hockey, and on the right is me and my son playing on the same team. And with that, I wanted to show you like a little anecdote of how a cone beam could be used a little bit unconventionally. So in one of our playoff games a couple of years ago, I injured my hand, and I got into my sitting on the floor, picked up my hands and took an image. And I wanted to compare healthy hand to an injured one before I started to call orthopedist. Unfortunately, I did have a little broken bone, but he told me, don't worry about it. It's going to heal, and it did. And the year after, I had in another hockey game, I had injured my foot. I let your imagination to run wild to figure out how I got this picture. But had a little injury. Anyway, back to teeth. So with the conventional orthodontics, again, patient gets in a chair, orthodontists use a traditional straight wire. They put the braces on, they put the wires in, they first level a line, and then they start moving teeth in more precisely. So moving teeth conventionally, direction of a tooth movement is determined by a bracket and the wire, and if there are any bends in the wire. And orthodontics, majority of the time, is dominated by something called straight wire philosophy, which is 100% of prescription is built into the bracket with no wire bends needed. But reality is there's thousands of brackets. Every orthodontist uses a different one. It's very challenging to consistently produce really high quality results with just straight wire alone. So because it depends on how good you put the brace on, what's tooth morphology. So perfect bracket placement is nearly impossible even with indirect placement. So orthodontists bend arch wires, change the brace positions to correct for certain little details. But so there is a lot of limitation of manual process because putting all those little details into a straight wire sometimes takes 6 to 12 months. But a robot can bend any memory or steel wires to perfection in about 3 minutes. And what that means, the technology that I want to introduce you to is something just as a small part of this lecture, is something called SureSmile. I'm sure a lot of you heard of SureSmile aligners, but not everybody may know the SureSmile technology itself. So it started with the digital imaging. SureSmile creates a 3D computer model, and SureSmile was a wire company before it became an aligner or ventured into aligner market. So SureSmile creates a 3D computer model from the iTero scan, and then or any intraoral scan for that matter, and then merging it with a cone beam. What you see here, it's once the scan is done, a practitioner receives a model where you could see roots, where you could see bone around the teeth, brackets on the teeth that are placed. You could merge that model with the smile. You could actually preset how you want your smile to look like. And this little animation video will show you just how this works. So for example, the teeth that have a little greenish color, that's the teeth where the patient is right now when the braces were placed. And then we're going to switch them to the white color is where the teeth are, that we want the teeth to end up. So you could merge that model into smile, photo, virtually remove the brackets, and literally preset how you want your smile to be at the very end. You can also notice that there are some dehiscencies around some of the teeth. So you can actually gear your orthodontic treatment by trying to put the roots into the bone rather than just randomly moving the teeth where, without any limits. And I'm sure many of you know that a lot of times orthodontic treatments long-term produces a lot of this recession. So there's a very, very precise positioning of these teeth with this technology. Once this setup has been completed, then orthodontist designs a wire, and as I mentioned earlier, the company has a robot that will actually bend those wires in 3D, and once the wires are placed, the teeth will move exactly where you set them up on a computer. So it's a digital imaging, treatment simulation, and robotic customization. But it's not just a wire making software, it's really the best orthodontic planning tool. And I'm just going to show you a bunch of cases that introduces this concept. So for example, this gentleman has been referred to me by a periodontist. He's been treated somewhere else. There is a very common problem, missing 2 lateral incisors in the lower, and orthodontist said, yes, now there is a room for the teeth. The truth is, as you already probably guessed, that there is enough room for the teeth, but not enough room for the roots. And the problem is that most people, when they look at the panoramic X-ray, especially if it's traditional panoramic X-ray, they're thinking mesial and distal. So those teeth are, if you look at this, you think maybe we could bring the roots of the centrals a little bit mesial and the roots of the canines a little bit distal. But reality is, if you look at it in 3D, this is what you see. So it's actually, because the panoramics is distorted X-ray, you don't really realize that these roots are actually perfectly parallel. But it's the crowns is just flared. So the roots really don't need to come mesial or distal. The roots need to come facial. And because you know where the bone is, you could create a plan where this happens. And here we go, 6 months later, once the wire go in, you could see that there is now plenty of room for between the roots for those implants. So there's before and there is after. And a picture with the fixture, with the implant fixtures in place. Another patient, 50-year-old lady, wonderful person, but she had an accident and she knocked out her central incisor and also fractured a buccal plate along the way. So when they tried to place an implant for her, the implant failed, and it failed twice. So the prosthodontist called me and asked me if I could just straighten these teeth, and he would put a bridge. To which what I have suggested to him is that there was a gentleman by the name of Vincent Kokich a decade or so ago, and he said that if we move a tooth over a dentulous space, it will create the bone. So my suggestion to this prosthodontist was, instead of just straightening out the teeth, let's take the lateral, move into a central position, and then restore that lateral as a central. And when we move that lateral over, it will create a nice bony ridge in the place of a lateral. So here we go, braces are on. We put a little fake pontic in the central, and as we're moving the lateral over, that pontic just gets shaved. As the process goes, again, very often what you see in the mouth, sometimes even though it looks like the tooth has moved over, the root has not. So there's still not enough room between the lateral and the canine. So all I got to do is just go back to my software, do a little virtual wire bending, and get that root uprighted. Once the braces come off, the prosthodontist did a little bonding on the central. You could see the implant placement into the lateral ridge, which was very nice. Then final preps and a final restorative work. So she's still ill class 2, but that wasn't possible to fix it orthodontically without surgery. But anyway, so you could see the before and after. But we created bone basically in the lateral place. So sometimes that we get patients and we don't really know what we could accomplish, what kind of restorative work could be done. So this young lady, she's actually a lot younger than she looks, but because she has a lot of worn down teeth, very deep overbite, and she obviously does not want any surgery. She wants to just to straighten them out and get a restorative work. But the problem is, it's hard to predict what can we do. So one of the beautiful things about the SureSmile software is I could just take a scan, and I could produce a virtual model where I see where the bone is and where the teeth are. So instead of me playing with the teeth in wax like we used to years ago, I could actually move the teeth virtually and decide if I could accomplish and position the teeth for that restorative dentist to accomplish what she wants. So we need to bring the lower out a little bit and yet not create the recession. So we could angle those incisors. We could intrude and upright the upper incisors as well and position them properly. So this way restorative work could take place. And also obviously drive these teeth back into the bone and possibly minimize the dehiscences. So to make the long story short, braces go on. Once the braces go on, just repeating the same plan, but now the plan has braces on. So from here, it's very simple. Braces coming off. You could see this spacing has been created around the incisors. the teeth have been positioned so the marginal, the incisal edges may have been different, but we geared the treatment towards positioning the marginal ridges around the incisors to improve the gingival architecture and gingival position. And once that was done, now the final restorative work went into place. So, you know, this kind of interdisciplinary case using that technology has become, you know, becoming very, very predictable. So obviously, she looks a lot younger now. So we like these patients, even if they're aliens sometimes. Just because I have this magical software and that I could really move the teeth into final position very, very accurately, the basic rules of orthodontic movement still apply. So, if, you know, for example, if I want to move a certain tooth a certain way, the rule of physics is still there. If I'm pushing one thing one way, something else got to go the other in the opposite direction. So in order to control the tooth movement very, very precisely, orthodontists, especially in the past decade or so, started using something that's called skeletal anchorage, or otherwise known as TADs, or temporary anchor devices. And what it is, it's literally just various types of miniature implants that don't integrate unlike real implants, but they could be used as anchors to move teeth in whatever direction we need, as if teeth are set in wax. So, for example, many of you are obviously familiar with this kind of situation. Patient has been missing lower teeth for a very, very, very long time. The upper molar has extruded, and now there is no room for restorative. In the past, this had to be either you know, done with a root canal and endo and make a shorter crown, or maybe extract and put another implant. But what it could be easily done today is I could, or any orthodontist for that matter, could put a small little pin, one on the lingual, one on the buccal, right around the roots of that tooth, throw in a little rubber band, and literally just reintrude the tooth back where it belongs. Just like this, and now you could see that tooth has been intruded, and lower restorative work went in. Same with the teeth uprighting. It is very challenging. It's difficult to upright teeth conventionally because teeth tend to not only when they get uprighted, they tend to extrude. However, if that's backed up with a little mini implant like you see on this picture, then the uprighting becomes pretty predictable without extrusion. We could use TADs to correct certain type of bites. So for example, this patient has a class 3 relationship, and I could put a pin in the back, like an intra-retromolar pad, and retract the whole side and position it into a more ideal relationship into a class 1. Another example of intruding the super-erupted molars to create room for implant work, slightly differently from the way I showed you before. Here we just placed a mini implant around premolar area, between the premolars rather, between the premolars, then anchored them and used the wire to intrude the first molars and second molar to clear room for the restorative work. Another example, patient has been missing a tooth in the back, and you can see the upper picture has a lot of space. So putting oops, sorry, just got, sorry, somehow I paused it for 1 second. There we go. So I placed a mini implant essentially next to, sorry. There we go. So again, put a little mini implant distal to canine, and we were able to bring the molar all the way forward where the tooth was missing. A situation like this where there are two impacted molars, first and second, they were going to extract both of them. However, that's really not necessary. So what I asked the oral surgeon is just to extract the first molar. Then what I did is I just placed a mini implant into a retromolar pad where that third molar used to be, and just upright it, that second molar, in this kind of fashion. And this is the before and after. You can see that second molar now in place. Another situation where the patient has a failed crown on number 29. And as you can see on this X-ray, there's just not enough room to place a clinical crown. The bone level. So what we could do is force her up that tooth. And in the old days, again, you'd need the whole set of braces sometimes to bring that up, or some sort of fancy mechanics. But today, just could put just a couple of mini implants and use a little spring to upright and force her up the tooth to give you more room to improve the clinical crown ratio, so you could put a nice crown on it. And you could see the amount of forced eruption. Now there's enough room, and then there's a final crown in place. You could eliminate, in today's orthodontics, you could really almost eliminate extractions. So for example, this gentleman never wanted to straighten his teeth because he was told that he needs to have teeth taken out. And that's really not necessary, because a couple of mini implants on the palate, and you could retract that dentition back into a more ideal position without extracting any teeth. There's before and after. Okay, you could correct certain borderline skeletal discrepancies, like this class 3. She has an anterior crossbite, and then so we opened the space for an implant for number 14, placed skeletal anchors distal to the molars, and retracted lower out of the crossbite. Since surgery is something she didn't want to do, and this was finished in 2012, and in 2018, that's still holding up well. Was holding. I haven't seen her since. This is a little bit more severe case. Again, this young lady said, "I don't want a surgery. I want." She was very reluctant to go through surgery, so she wanted to have an alternative, and she agreed to that. We could probably bring the lower teeth. She does have a little bit of a functional shift forward, so maybe her class 3 is not as severe as it looks. But with the use of sure small wires, we brought the teeth out. Yes, they certainly ended up a little bit proclined, but you could see there are tads in the back there, and we're retracting lower back, and here we go. That has been corrected. Certainly not ideal, but she's very happy. She looks great, and she's very happy about this very, very nice change. And a profile improvement as well. Okay, as I mentioned today, the extractions are really not necessary. So for example, this young lady, she has severe crowding. She's got her midline is completely off. That red line on the bottom, that's where the facial midline is. She's got a blocked out lateral, but she already lost molars, as you could see. And then she again was reluctant. She really didn't want to lose any more teeth. So how could this be? How could this work out? And it's again, not a very complicated. Actually, now that if we have an anchor and we could move things where we need to, things become a lot simpler. So I placed a tad in front next to the molars. We brought the right side canine back. Then we've fixed the midline, got the lateral, and this is just a little short progress. And you could see on the bottom left there is a tad in front of the molar. So this is just only took 10 months to get there. Then she was getting married, so we had to get the braces off and finished her up with Sure Smile aligners. A few more just to upright the teeth and give her some final look. This is actually not a final picture, but still, it still was work in progress. But she was able to go ahead and get married with a beautiful smile. So, and without losing any more teeth. Sometimes this allows to solve another type of surgical issue, like a class 2. So this young lady has already had treatment. You can see she's missing all her first premolars, yet she's got a horrible bite, anterior open bite. She's very gummy. she does have some misalignment, and again, but surgery scares her, so she does not want a surgery. So what can we do for her? In the old days, again, we used to do something that's called VTO, visual treatment objectives. I used to put cases in articulator and take out the back molars and see maybe some of the class 2 cases, they're really not horizontal class 2s, they're vertical class 2s. So if you take the molars out of occlusion and the lower jaw auto rotates forward into a class 1, that's vertical class 2, which in this particular case was the case. So if we were to somehow take her molars back up into the bone and intrude them all, she would auto rotate into a class 1. Today you could test that actually on the same SureSmile software in the kind of a virtual articulator. So set the condyle and see how the lower jaw would come forward. So that would work. So that's what we did. She has a bar across to prevent the molar tipping. You could see the anchors that they were placed by a surgeon. Actually, these are anchor plates, and we intruded her upper lower molars. When the intrusion actually over intruded a little bit, you can see she's almost developed the posterior open bite. So this was a scan after the intrusion was pretty close to completion. Then once that happened, we scanned her and to get the SureSmile wires, and this was how the final plan would work out for her. As we intrude the rest of the arch, we would solve the gummy problem and the class 2 problem. So that's how it worked out in real life. So you could see she's a lot better smile, no more gummy, nice overbite, and aesthetically and functionally well. Another gentleman, he's a nephew of a dentist, and he just finished his orthodontic treatment. And when the dentist obviously did not want his nephew to lose any premolars, because the orthodontist told them that in order to reduce this significant bimaxillary protrusion, you need to extract premolars. And then because the premolars were not extracted, so the kid ended up with a lot of protrusion. So the uncle was upset, called me, brought the kid, and it's really the extractions were not necessary. So we could put a small little bar on the palate and retract and intrude teeth. So same as in the other patient's case, the lower jaw comes more forward. You can see a little bit of you can see a lower tad as well to retract the lower. And this is before and after treatment. You can see a lot less strain on his lips. The most remarkable thing to me was, so this is how much the teeth have come back. So the yellow lines is where he was, and the red was post-treatment. But not only that, if you look at the change in his airway, because of how much the lower jaw came forward, it's literally almost like having a MMA surgery. The kids actually could sleep a lot better. It turns out, in retrospect, he was a snorer, but he stopped being a snorer, and went on winning a state championship in wrestling. This kid is missing his lower second bice, and certainly we could just leave the room for an implant. However, he has an impacted third molars. So sorry, I got pause this 1 second. He's got impacted wisdom teeth. So his choice is extract the wisdom teeth and leave the spaces for the premolars, or just slide all 3 molars forward. However, with conventionally, if we were just throwing the braces, try to close the space, the molars are too big to go forward, and you would have retracted all the lower teeth back, increasing the overjet. But if we put a couple anchors right next to canines and anchor the front teeth in place, we could actually take all 3 molars and bring them all the way forward. And again, SureSmile plan, because the wires are custom, we've got to make sure that the roots also are uprighted properly. and voila, this is, you know, space is closed. So I know it's probably took somebody's business not placing implants, but you know, the kid and father were happy. Another young lady, a severe class 2. Also, she has also a sleep apnea, and I'll spend a little bit of time on that. You can see how narrow her airway is, and as my staff joked, you know, her teeth walked in before she did. She's got such a severe protrusion. So what could we do? Same thing. We expand it, and then on this bottom right picture, you can see that she has two palatal TADs, and we retracting and intruding the upper arch simultaneously. Essentially, by doing the intrusion, the mandible auto-rotates forward. You could see a huge change in the airway. Sleep apnea went away. She feels better, sleeps better. There you can see the 2 TADs, and you can see the tremendous reduction in protrusion. And also, the lower teeth were not thrown forward. So the lower teeth stayed at a nice angle. And the profile improvement also quite substantial. And also not gummy. And no extractions. A little bit more complicated. This young kid has a complete crossbite on his left side. If you look at it in a cone beam, his lower teeth are completely inside, complete on the inside of the upper. And to treat this actually could be very, very challenging. However, not with the latest stuff. So again, very simple. I want these teeth to move this way. Easy. Place a TAD next to the molars on the buccal side. So we did that first. However, it wasn't sufficient. So we added another one on the palate. So on the palatal TAD, I want to move the upper teeth in, and I want to intrude them a little bit. On the buccal side, I put the TAD into the that connects into the buccal shelf, so it's not in the way of the molars, and we're bringing that side out, and voila, now the crossbite has been resolved.
Dr. Lipkin, I have a question that came in. It says, do you have issues with TMJ with these movements?
Well, I am very wary of TMJ in particular. I part of my practice is devoted to TMJ, so of course, for example, as you saw right here, they have some. These are already remnants of the centric stops, but they're actually done in CR. So you're absolutely. It's a great question.
And then there's a follow-up to that. Sorry. It says, with these rapid movements, do you have issues with root resorption?
Well, they're not that rapid. The movements are, you know, normal orthodontic movements. Sometimes the fastness comes not from the tooth moving faster, but the tooth moving more precise, because conventional orthodontics move sometimes round trips the teeth. When teeth go into very specific direction directly where they're supposed to be, the treatment is shorter just because you avoid round tripping them back and forth. That's a great question. Also, a lot of times you get a root resorption when braces are on for a very, very long time, and you retract the teeth and the roots end up hitting the cortical plates, like in extraction cases. That's where a lot of root resorption cases come from. So that's a great question, but no, I don't see a lot of root resorption, but certainly occasionally it happens. All right, so there we go. Another young lady with a very, very similar situation. She has her lower arch collapsed on the lower right side. She has a complete overbite. And as you could see on this picture, she also has a canted smile. She wants some veneers, but obviously it might be a little challenging to get that done right. So what can we do for her? You could see how her bite is on that right side. Conventionally, probably a little challenging to do, but If we have a proper anchor systems, that becomes a lot easier. So this is our first SureSmile scan when the braces just went on, and you can see this is on the bottom left, that dehiscence on that canine is actually what was there before we started treatment. So, and on the bottom right, where you see the white teeth, that's where I want the teeth to end up. So I'm trying to move them into the bone. And in order for me to level her canted smile, I'm going to place a TAD on that upper right side and anchor the right side so we could move it up. So here we go. There's on the bottom left picture, you can see the TAD, the wires going in. We're fixing the crossbite. And again, another progress picture, the crossbite almost completed, but some of the teeth are still not quite there. So sometimes there is a need for a second scan to get the bite into the right place. But what I wanted to show you is that this was a scan on the top left is where we would just scan her when we put the braces on, and that was the plan. And now when we scan her for a scan 2, you could see how improved that canine bone has become. So on the upper left is when right before treatment. Now this is the progress, and you could see that the canine has recovered some of that dehiscence just by virtue of moving it back into the bone. And this is again from the scan 2, and on the bottom right is a final X-ray. Again, I didn't have a three-dimensional reconstruction, but you could see a much nicer improved bone on that canine just when you move it back into place. So again, her progress picture, final wires went in, and on the upper left is where she was. In the middle is the plan, and this is the almost finished. And after that, she got some long-awaited veneers. So started canted, now she's straight. Okay. Another situation that happens not too often, but in this kid's case, his upper left canine and premolar switched places. They're completely transposed. You could see the canine is right there. And in the old, again, it's very difficult to fix this. And very often the orthodontist would move the premolar all the way forward and positioning the canine into place of the first premolar. But as we know, that's not really an ideal situation. And but to switch that transposition is a little challenging. However, if you have the right tools, then it becomes a lot easier. So place the TAD on the palate, move the premolar out of the way, put another TAD distal to lateral, move the canine forward. But it sounds, to start with, sounds very, very easy and simple. However, you know, this looks like they almost got their transposition completed. And oops, and this is a little near disaster happening. You can see the canine started to get recession. So this was my mistake because I was a little anxious to get them crisscrossed. Turns out the crown's crossed, but not the roots. So that became a problem. So fortunately, having knowing exactly where the roots are, I could actually create a custom wires and take those roots and uncross them. So this was a first plan. And that those wires came in, and the first set, these wires were just designed to uncross the roots. So once the roots were uncrossed, that's a progress, and that's another progress. Once the roots were uncrossed, we rescanned, and from here, now we just have to create a plan to position the to get the final occlusion correctly. So there we go. And so the new plan from here is I don't have the final picture, but this is just a oops, sorry. This is how sequence took place. So initial, move the premolar out, then upright the roots, and then realign and scan to finish up the case. So Another young lady, she's missing both laterals. And it's a challenging situation because she's wearing some sort of a removable contraption that has an incisor in the middle. However, she's very unhappy about that and she wants to have it fixed. But regardless of the situation, she does not really want to go too much without her teeth. So we could also use those TADs to put some temporary restorations. So for example, in this here, what we could do is we could take the patient who is missing some teeth, put 2 TADs on the palate, and then create a little contraption that could actually have a framework that extends and replaces the laterals or any other missing teeth for that matter. So from the front would look like this. It's a great little contraption because it also becomes a perfect anchor unit, and you know, and solves all the aesthetic issues. So just another view of it. And actually, I have a little bit of better system now, but just another example, patient missing multiple teeth, doesn't want to walk around the teeth while we're aligning everything else. So same story, 3 teeth replacement, another multiple tooth replacement as a temporary while the orthodontics take place. But back to this young lady, same, so that contraption goes in. She now has a teeth that could, you know, that serve her aesthetically, serves our aesthetic purposes. She doesn't have a flipper that will interfere with orthodontic movement. Not only that, those teeth that are attached to the TADs, I could actually use as anchorage. And that's exactly what happened. We needed to actually bring the sum of these teeth a little bit more in to reduce the overjet and upright the roots of the centrals. And because I have 2 teeth that are attached to the mini implants, it's a perfect anchor system. Once that all the movements were accomplished, then we just rescanned and actually had to reset that contraption to make it to fit the final position of the front teeth. And once the case was finished, now she's ready to have implants restored. The only problem with that is now she's been walking around with this appliance for about 2 years now, and she's not in a rush to change it. I hope it'll break soon so she could go get her implants. Another young kid with.
And I have another question.
Uh-huh.
It says, how much has CBCT technology become state of the art for orthodontics?
Oh, it's tremendous. I don't think I could live without it. I take Chromium on every single case. I know everything in 3D. I know airway. I know joints. I know any kind of roots that are off or crooked or yeah. I couldn't practice without Chromium. So it's like I said, I when I saw it in 2005, I bought it in 2005, and I've had the cone beam since then. I've replaced, you know, I had original iCat, then there was a 2nd generation iCat, then now it's an iCat Flex, which is the latest one that I've had for the past 5 years. So anyway, with this gentleman, he's missing laterals. I'm not personally. I'm not a fan of putting canines into lateral position. It rarely looks really good. So I prefer to open the space. However, sometimes the problem is, you know, we're going to take all the teeth from canine to the molars and move them back without affecting anything else. How can we do that? Same principle. I could put 2 TADs on the palate, use that to take all these back from the canine to the 2nd molar, take them all the way back, distalize them, opening space for 2 laterals. And then once the distalization has been completed, I could, and you can see that's the progress X-ray. Now we have a nice space for implants, maybe not yet, but close to it. And then I could use the same TADs to now that I'm going to start finishing my orthodontic work, I could you know, remove the distalization unit and attach my lateral incisors to those very TADs. So this way I have my aesthetics covered, and I could keep that, and I actually keeping it until the kid is ready for real implants when he's going to be 18 or 19. So that's another, just a progress picture. I just realized that I missed some of the HIPAA issues, left some of the eyes open. Anyway, so I wanted to spend literally just a couple of minutes on orthodontics and sleep disordered breathing. Not only in that, just because some of the technology allows to do other things. So sleep disordered breathing is really not just adult problems, then, because they do begin in childhood. Snoring in children kids should not snore. Up to 12% of children snore, have sleep disturbances. There is also a concept of upper airway resistance syndrome, where kids don't actually have actual sleep apnea, but let's say the airway and the upper airway is so narrow, it creates physiological effects similar to sleep apnea. And a lot of there's about 30% of the kids that diagnosed with ADD or ADHD or other behavioral issues, it really starts with sleep deprivation because of sleep apnea. So just some research, they took 79 children with obstructive sleep apnea. They were assessed, and before 30% of those kids met criteria for ADHD. 1 year later, half of those subjects did not qualify for ADHD once their airway was improved. Whereas the obstruction mostly in the nasal, it's an upper airway. It's either enlarged turbinate, deviated septa, narrow small nares, sinus issues, and so on. Orthodontists are really in a unique position to screen for airway problems, especially to answer that previous question with the cone beam. I mean, this is absolutely invaluable information that could be seen. But sometimes even we talk about airway, but why nasal breathing is so important and mouth breathing is detrimental to patients' health. In 80s, this gentleman, Dr. Louis Ignara, received a Nobel Prize for discovering nitric oxide and its effect on cardiovascular system. So body uptakes the nitric oxide actually during nasal breathing in upper airway passages. Our body generates nitric oxide in the sinuses, in paranasal sinuses. So when we inhale through our nose, our nitric oxide enters the airway, and then being delivered to our airway, to our lungs. It's also modulate pulmonary function in humans. It reduces pulmonary vascular resistance, improves arterial oxygenation, and among the various biological properties of nitric oxide, it's also a natural antibiotic. So kids who are mouth breathers, they don't receive this. That's a health issue for those kids and adults, as a matter of fact, too. So orthodontic treatment has really unique position to change that environment by expanding the airway, and I'm sure I'm going to briefly mention the palate expansion, which is making room for teeth, breath, and the tongue. There's tons of different research. I'm not going to bore you with that. This is two different types of conventional expanders that affects a growing patient, and I want to underline this. It's for a growing kid, maybe up to like sometimes before puberty. Sorry, all of a sudden oh, there we go. So for every millimeter of expansion, the nasal volume increases significantly. So, by 10 millimeter expansion gives you almost 100% more air passing through the nose. Also, by using palate expansion in kids who had enlarged tonsils and adenoids, so this was a research done a few years ago. They took 3 different groups. One had enlarged tonsils and adenoids and only had them taken out. The other group had also large tonsils adenoids, but they only did expansion, and third group did both. Kids who actually had palate expansion fared better 80% of kids in that group received improvement in comparison to just removing tonsils and adenoids. But kids who had both tonsils and adenoids removed and a palate expander, it was 93% cure rate. Expanding the airway and making kids breathe better sometimes affects on, it's a research on their nocturnal enuresis, so bedwetting improves conductive hearing loss. But what I really want to talk about, not that we touched upon general expansion, is something that's called MARPI or MSC. MARPI stands for Mini Implant Assisted Rapid Palate Expander, and MSC is Maxillary Skeletal Expander. And it's really a game changer that we've been using for the past couple of years, as I'll show you. So MSC is a device that's been invented in Korea. It's basically a palate expander, but if we use a conventional palate expander on an adult, it's just going to tip the teeth and move them right out of the bone. Or actually, for that matter, for any patient, not just an adult, even if it's a post-pubertal teenager. So the maxillary skeletal expander actually is an expander that's attached by 4 miniature implants right to the palate. So you really not putting the force on the teeth, you're putting the force directly onto the bone. And because it expands the palate and the base of the nose, it improves the significant airway, and improves respiratory function, improves sports performance, improves what most remarkable is it improves obstructive sleep apnea, because when you expand the palate in adult, it stretches the soft tissues like a soft palate, and in many cases the apnea completely disappears, or severe apnea could become very mild. Me personally, as I started using MARPIs in my practice, initially I started using them to gain space or accomplish certain changes for my orthodontic treatments, but anecdotally, those patients were reporting, "Oh, I stopped snoring. Oh, my wife told me I stopped snoring. Oh, I'm not using CPAP anymore," and so on. And there's a lot of research that exists that shows that when there is a skeletal expansion, it improves the airway and increases airway flow. This is just from my communication with some of the patients that were happy that they were able to breathe through the nose, and one has been was never able to breathe through his nose for 30 years, and now after the skeletal expansion, he can. So back to clinical cases and how that could work in clinical practice, not just improving sleep apnea alone. So a young lady like this with a significant class 3, she was told that she needs to take 4 teeth out to straighten her teeth, but obviously, she's only 16 years old. So what if she grows more? And so taking the teeth out would be really a bad idea. So this was my first attempt actually at the skeletal expansion about 10 years ago, where I placed two mini implants and had my palate expander supported by those mini implants. Her palate split beautifully. You can see that space between the front teeth, which is classic sign that the expansion is working. And from there, once we expanded her, the rest was just straightening the teeth. So it was a nice improvement. And she obviously didn't need any teeth taken out, and it worked out very well. And then actually that's how she grew up and never needing surgery either. She never outgrew it. And a lot of patients that actually, a lot of class 2 patients, they're in severely crowded cases, we could use that same expansion principle and make room for airway and the tongue. So this kid, severely crowded, again, he was told he needs to take 4 teeth out. And again, I use expander on him purely for to gain room. But anecdotally, mom said, "Oh, by the way, he stopped snoring." So you can see this is, again, just another variation of conventional expander that's supported by 2 mini implants. And then things are straightened out. And that's his progress. That's his finished X-ray, finished result. As you can see, all the teeth are fitting. plenty of room for everything. Nice profile change, functional and all. However, 5 years ago, I talked to a friend of mine, and he said, well, you could do the same for real adults. And this young lady, she works for a local oral surgeon who everybody knows, and she's one of his receptionists, and she came for a consult, and she told me that she was told by her boss that she needs a surgically assisted palate expansion. So I said, well, listen, I just learned about this mini implant assisted rapid palate expander, MARPI, or MSE, and would you like to try that? Would you like to be a guinea pig? And she agreed, because she really didn't want to do the surgical part. So we installed that expander for her, and it worked. So you could see again that on the right side, you could see that characteristic space that tells us the expansion is working. So this was my first one. I did a few mistakes there, but case worked out nonetheless. You could see the change in the expansion, and from there was just became a routine orthodontic case. Another example, which is now that I've got a little braver, was that. So this gentleman came in, and he needs room for 2 implants for the laterals, and he was told that he needs a surgically assisted palate expansion. However, I told him that, well, that no longer true, and we offered him an option of using a skeletal expansion, and he agreed. However, he didn't want to walk around without without these laterals. So one of the things that I did is, when I placed his MSE, the skeletal expander, I also used these little extensions and made him temporary laterals, which was good, because it definitely worked. You could see the space between the front teeth, so expansion is working. And then once we finished with the expansion, I actually used those laterals as an anchors to align his front teeth as well. So there he is. On this 3D rendering, you could see actually a split between maxillary shelves, so it definitely worked. Now we have plenty of space to position these centrals and make him room for laterals, so that's my Sure Smile plan. And put him into his smile, so the teeth needed also to come down a little bit to give him a better smile line. And again, that's a progress, almost at completion. So taking X-ray, almost there with the space for the laterals. You can see the comparison. Now we have enough room. So his Ceph, you could see again the MARPI placement. And he also stopped snoring. So and you could see that now he's just I don't have a picture with his final dental work, because I haven't seen him after he got his implants placed. Right now he's just wearing Essex with 2 teeth. So again, the before and after. In some of the severe class 3 cases, like this little boy, there's also anecdotal reports that those MARPI expanders work really magically. And this kid came in, he had a absolutely severe sleep apnea, was actually referred by a sleep physician. And if you look at his pediatric sleep questionnaire, you could see that, the mom checked off almost everything on this list. She's snoring, he's misbehaving, he's absolutely awful. And here he is just a couple of months later, where he doesn't have a crossbite anymore. He's expanded, and we used a face mask on him to track the maxilla forward. That's how we corrected his class 3. However, the most remarkable thing is that when mom brought him in, she really cried, because the kid is a different kid. He's no longer snoring. He's behaving. He's listening. He's attentive. His grades went up in school, and so on. A very similar story was this boy, another class 3, another airway issues. Starting with the MARPI, used aligners to upright his lower molars to catch up with the wider upper. And voila, there he is at the end. So but it works in kid really, really well. What about adult? In 2012, the class 3 like this, even very mild class 3, was a surgery case. So yeah, it was nice. We treated this guy in 2012. This is right post-surgery. Did a little tweaking, and this is him after surgery. Nice function, nice improvement. But the surgery, if I'm sure many of you have seen orthodontic surgery, is extremely brutal and extremely invasive. On this mild class 3, it's really, I don't know, to me it feels very invasive to fix this mild correction. So turns out that just like in that little 7-year-old, if we split the maxilla non-surgically with a MARPI device, MSE device, and we actually put a traction on like a face mask to try to bring the upper jaw more forward, it will work in adult too. So this is a 24-year-old who refused the surgery, and I told him that we could do, and he agreed. He was a guinea pig in that department. And so you could see he's now, look at his profile change. His maxilla actually came forward, and I'll show you in a cone beam superposition. So that's a progress. Now we from here, it just becomes an alignment to get his teeth aligned. But you could see the maxilla came forward, actually mandible came forward a little bit also. So, that's, before and after. So mild class 3 like this could be treated non-surgically in adult these days. You don't need the surgery anymore. You could use MARPI as an anchorage in severely crowded cases. So for example, if you follow the sequence on this picture, this young lady has completely blacked out lateral and premolar. And she also was told that she needs extractions, and it's really not the case anymore. So we used the MARPI, we expanded the maxilla, and then I used that as a perfect anchorage to distalize the right side and make space for all the blacked out teeth. Similar story. This kid's has blacked out canines. After the expansion is done, we used the MARPI to distalize the teeth, and now made room for all the teeth. So now we basically gone over a lot of TADs and all of technologies that allow us to move teeth. How about we wanted to move them even quicker? Some of you may have heard the term Wilcodontics. Also, the scientific term for it is accelerated osteogenic orthodontics, or AOO, sometimes called PAOO, which is periodontal accelerated osteogenic orthodontics. Basically, what it is, it's a keratotomy with bone grafting. Turns out when you do a minor surgery on around the teeth that you need to move, the physiology of a teeth movement changes. There's something that's called RAP phenomenon, rapid apposition phenomenon, where the bone behaves differently when you start moving teeth through it. Essentially, if you, instead of moving teeth through the bone, like in conventional orthodontics, you could move the teeth with the bone and actually create the bone where it wasn't before. So Wilcodontics advantages, it's significantly shorter time because teeth move a lot faster, as you can see in a minute. It lets you safely stretch the bone envelope with a lot of better periodontal support at the end. Create bone where it wasn't before, and it less root resorption, better anchorage, and better stability. I was privileged to lecture with Dr. Wilco, and because I've been using his technique for over a decade. So this is what the surgery looks like. Essentially, what they do is they put cuts between the roots of the teeth, and then they lay a bone graft on top of it. And then that changes physiology of how teeth move. You have a window of about 3 months where you could move these teeth very, very rapidly. And then that graft will turn into a new bone, and there'll be less recession. There'll be less dehiscences on these teeth as from where they started. This is a progress orthodontic case, post-Wilcodontics, and you could see the improved amount of bone on both upper and lower incisors. So this is how fast this goes. So this is young lady, class 3. So she's got skeletal asymmetry. She's got an impacted upper left canine. This is one of my very first vulcodontics cases, but it still amazes me to this day how quickly that went. So she did not want to do surgery. Probably today I would have used maybe a skeletal expander on her. At that time, it was not an option. So we offered her an option of using vulcodontics. And this is how fast it went. Now, this was 2 days after the surgery, after the vulcodontic surgery. This was 2 weeks. This was 4 weeks. And what you see on the upper left picture, we did the exposure, the surgeon who did the surgery, they did this canine exposure at the same time they did the vulcodontic surgery. So now 6 weeks, 8 weeks, and you can see that canine started to come in. At 10 weeks, that was fully in. At 14 weeks, it was almost completely in place, and we started finishing it up. And voila, the whole thing took just about over 4 months' time. So 20 weeks. So, you know, which probably would have taken, I don't know how many years back then. So, but, you know, yes, it's amazing, it's fast, but to me, that wasn't really the only thing. What you could see is on the upper left cone beam reconstruction, this is a initial cone beam, and you could see there is a dehiscence on the lateral, and you could actually make out the roots through the bone. Now, if you look at the superimposition of where the teeth were and where they ended up, you can actually see that those front incisors, they actually went through completely forward, you know, bodily. And now on the bottom right, you could see that how much more bone now around these front teeth. So that to me is probably the bigger value of vulcodontic surgery in comparison to you know, just the speed of treatment. So this is the same lady, same girl, about 7 years, no retention, things are absolutely stable. So that is pretty remarkable, I think. So call the dentist about missing dentures, call the doctor about embarrassing new discomfort. So we could move really with the light speed if we combine all this cone beam, sure smile precision with studs and vulcodontics. This is the fastest case I've ever treated. You know, the reason we wanted to do vulcodontics here, again, not because we wanted fast, but because there's a lot of dehiscences on the lower roots and we didn't want to make it any worse. So that's where she started. She's got sure smile wire about 4 weeks later, and in 10 weeks, she was completely done. And actually, in vulcodontic surgery, if you notice on the bottom central picture, she actually has an increasing keratinized gingiva, which is very typical for vulcodontic cases. So that's before and after, just a couple of months. And you can see right here, so these teeth went completely forward, and there is more bone on them than was before. So a couple of funny pictures. This kid, you might wonder why I'm bringing a 9-year-old into a discussion into this segment about the vulcodontics. Now, it turns out he had 2 cuspids that were completely in his chin. So the dilemma is, if I wanted to bring those cuspids to where they belong, I would have to either move them through the air, or I'm risking running these canines into the roots of the lower incisors and possibly losing the incisors as long as the canines. So how can we avoid it? So it turns out if you do the vulcodontic surgery on these canines, now you move these canines not through the air, but through the graft. And then you could, by using skeletal anchorage, you could bring them back and position them into the right place. So the vulcodontic surgery was done. You could see their tads in where the baby teeth used to be, and a little contraption that helps us to direct the tooth movement. And there's our canines. Now, I'm just going to move back for 1 second. The little redness that you see around the neck of the canine, that just inverted epithelium. That's why it looks red. It will keratinize later, and you'll see it in a second. So that's where the canines were, and now they're in the right place. Once they're in the right place, now we just need to position them a little bit better orthodontically, get the torque proper, get the roots into the bone more, which SureSmile software comes handy. Custom wires, and voila, that's the finished case. And you can see again, nice gum support around those canines. Now, how about this type of canine? It's in the chin. And when I showed this patient in the lecture to a group of oral surgeons, every single one said they would just want to extract it. But it really doesn't have to. So you could actually bring that canine in. So just through the use of the Wilcodonic surgery. So that's how exposure looks like. They have to remove all that cortical bone and fill it up with graft material. And then you could take this and you could bring that canine around the lower incisors. That's a progress. And voila, now we have that canine in. And you can see all that defect that was there during the surgery, it's completely filled in. There's no hole in there. And this is kind of puts it all together. So young lady, severe sleep apnea, she's got severe crowding, perio issues. You can see there's some bone loss in the front. And how do we get this worked up? So in the past, it would probably, again, if we talk about 15 years ago or so, 10 years ago even, would have to extract the premolars to position the teeth to get this young lady for the orthodontic surgery. Today, that doesn't have to happen. She had the Wilcodonic surgery done instead, and we placed in anchors. So in order to level and that huge curve of SPE and distalize the whole lower arch. And she has done Wilcodonics on the upper, so this way we could expand safely and improve the bone support for those teeth. So you're seeing the progress. Now the teeth are almost leveled. So this is right before the surgery, and this is actually right post-surgery. Sleep apnea was gone. She's now she's a completely different human being, and you could see the amount of keratinized gingiva around those teeth post-Wilcodonic surgery. And now just post-surgical orthodontics just to finish it up, and that's her final result. Now she just needs some veneers and restorative work. So what do we want from the orthodontics and can be delivered today with 3D digital orthodontics? We could deliver precision diagnosis, which is use of an iCat and SureSmile, precision in treatment, absolute control of tooth movement, speed of treatment, and on top of everything else, airway health. Yeah, we were serious about that. A patient experience usually less discomfort, shorter treatments, better result, fewer visits, a better cooperation. And for the interdisciplinary care, the computerization of the treatment plan allows for better communication. You could explore multiple treatment options, truly accurate tooth positioning, and teeth are really set and waxed because you could move them exactly where you want. Possibilities that are not available just 10 years ago. Patients come back quicker for restorative work, patient experience better in a shorter time span. So that wasn't a chicken. And thank you so much. I appreciate you having me. I actually finished a few minutes early, so if you have any questions.
Great presentation, Dr. Lipkin. Those cases were amazing, I have to say.
Thank you.
I say we give everyone just a few minutes to either type in the chat or raise their hands before I say there are no questions, because I always say that and then questions pop up. Okay, here we go. Got a few coming in. Here we go. Are the papillas maintained during the Wilkodontics? Is that correct?
What is that again?
It says, are the papillas maintained during the Wilkodontics?
Yes. Yes, maintained, and sometimes even improved.
Okay, and then what kind of bone graft do you use and why?
That I would probably refer you to ask that question, refer to Cheng Han, because he usually does my Wilka surgeries. I don't know which particular graft. I think it's allograft, but I could be mistaken. I just don't remember. But we took a course with Steve Moss before, and then Cheng Han went and took the course, and we've been doing that for a while, and the results are usually outstanding.
And then I see an awesome thank you.
Thank you.
Double checking. Okay, are you performing more Wilkodontics now or MSE?
More MSC. Because it really delivers an amazing airway experience. Right now I've finished about 400 MSC cases. Well, not finished, but in progress or finished. So for the expansion, I will use primarily MSC. If there is some issues with, let's say when we need to, when we expand the upper and we need to lower to catch up, then we might consider doing the Wilkodontics to prevent a recession to improve the bone support for the lower teeth. There's another term you may have heard for the Wilkodontics. It's something people call also SFOT, which is a little diluted version of Wilkodontics. There is a few variations as well.
Okay, thank you. I don't see anything coming up. I don't know if we want to give it another minute or two. That's up to you guys.
No, I think it's good. I think the explanation of the presentation was very well done. So not too many questions probably. All right. All right, Dr. Lipkin, thanks again, and looking forward to working with you.
Oh my goodness, he just texted me. He says his
froze?
computer just died if he's frozen.
Yeah, he looks like he's frozen. Well, super.
Okay, well, I guess that was perfect timing.
I want to thank everybody for coming on tonight, and we will see you all again May 3rd, if not sooner. Thanks. Have a great evening. Thank you, Sarah.
Okay, have a good evening, everybody.